Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I'm a filmmaker and writer by trade, among a few other things. But I've been working with CCF for over 10 years at this point, creating all kinds of videos, live video series like the one you're going to watch today, documentary, like patient-centric documentary stories, which we're in the middle of a series that we're releasing currently as well, treatment-based videos, conference videos, hundreds of videos in that span of time, but all with one central mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do today. Now, this show, Luncheon with the Experts, the value that, as I see it, is twofold. One, the information that you're going to get from our specialist, from our expert about this disease, and two, the shared experiences and the shared stories and the support from the community. The community, the NET community overall is extremely strong and supportive. The community within that community that we've cultivated here on the show is equally as supportive and strong. And so I encourage you, if you see people in the comment section, they're already saying hello and where they are signing on from in the world. We want to see that. We want to see how far these programs reach. So if you're new to the show or new to this journey, I encourage you to embrace that. We already got Australia in the house. Love to see you, Vicky. People all over the world tune in live, even when they maybe should be in bed. That says a lot about the show. So reach out, tell the people who you are. I promise you they will embrace you back. You want to utilize that resource just as much as you want to understand more information about this disease. You want to lean on the people that are also navigating this journey alongside you. Before we get started, we want to thank our sponsors, Ipsen Biopharmaceuticals, because without their support, simply we couldn't do the show. But we have this disclaimer from them that's very important. And that is that the opinions expressed by the guest presenters today, as well as the questions that you all at home, the audience, ask, haven't been created or suggested ahead of time by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. So audience members should not rely solely on the opinions or information expressed by the guest today, and should seek guidance and direction regarding any choices they make about their health or treatments from their own medical advisor. So that last line is really the takeaway I want you to focus on. We don't know your specific case. Most likely our guest doesn't know your specific case. So we're going to give you some good general advice. We're going to give you some good answers to your questions, hopefully. Take that general advice and those answers back to your home team, which does know your specific case, and make the best plan and path forward for you. Because although I am not a medical expert, working alongside this disease for 10 years, I've learned one thing pretty definitively, and that is that each case of this disease is unique, and therefore each plan and path forward is as well. Folks, today I am very excited to welcome back to the show almost a year ago to the day. I think it was the 16th of September. Today is the 15th of December, I believe. That is accurate. Dr. Namrata goes by Neena Vijayvergia. How are you, Dr. Vijayvergia?
I'm very well, thank you. Yes, it has been exactly.
Isn't that crazy?
I actually was confused. I'm like, is it last
Right.
year?
Your Calendly link was like September 16th, 2021. Anyway, I'm happy to have you back on the show. I know a lot of people are. In fact, we already see one of your patients. So in this case, Glenn, you maybe can ask specific questions. So some people are anticipating this show. We see a lot of people filling up the room already. But for those who aren't familiar with you, tell us a little bit about yourself and the role that you fill in this NET community.
Absolutely. So thank you so much, first of all, Wayne, and the CCF team for having me and for this whole series. I actually watch it myself. It's sometimes educational to me as well. Trust me. As I said, we are lifelong learners as medical providers. We learn every day from our patients, from providers, from our other colleagues, etc. I am AGI, medical oncologist, recently promoted associate professor in the Department of Hematology Oncology here at Fox Chase Cancer Center in Philadelphia. My clinical and research interests focus around neuroendocrine cancers. I also do colorectal cancers. These are like my two big areas that I work on. But neuroendocrine cancers is my passion, and definitely I work every day and strive to see patients and see how I can make the lives of our patients better, because this is definitely a disease which has a lot of a symptom burden, and patients are sick for a long time, and it is a very unique type of cancer. So I'm very fortunate to be a part of this community in some way, shape, or form.
Are those things that you just alluded to why you're passionate about this disease, like the longevity and the fact that you can work with patients for a longer time, or what is it that?
I think that is, for me, the biggest difference was the stark difference of neuroendocrine tumors compared to the other cancers, and
Mm-hmm.
how it takes a lot of understanding to just know and experience to just know and treat patients with this cancer. Like, is it like some people dismiss it because it's not growing that fast, the others forget, how sneaky this cancer can be and can just creep up on you, and how things grow. It's a very unique cancer. You need a special skill set that is different from, like, if you manage colon cancer, you probably can go and manage lung cancer too with a little reading.
Uh-huh.
Neuroendocrine cancer is a very special subset of cancer, which is very different and unique. And the whole idea of, the hormones, and then the interplay of not only that I'm actually treating a cancer which has a mass effect, or which means it grows and causes effect on the organs, the hormonal aspect of neuroendocrine cancer is very enticing to me as well. And learning about it and how we can address this rare cancer makes me very excited to work, except also the fact that I know my patients for a long time, and I get to work with them and actually become a part of their lives too.
That is awesome. So, folks, here's how the show is going to go today. I see a couple people. Kathleen from Chicago suburbs. My goodness. Kathleen, where exactly? Because I alluded to a documentary series that we're doing right now. In the next episode, I was in Forest Park filming a NET patient there. So I'm just curious. That episode is coming out in a week or two. And we also have it looks like a new person from Zimbabwe. Love to see that. Sibong in Kosi. Let me know if I pronounce that okay, but I want to say welcome. I haven't seen your name before, so that is awesome. Folks, before we get started, I just want to touch on something Dr. Vijayvergia said that is really exciting to me. I really love to see, she said something about being a lifelong learner, specifically with this disease, and you watch the show. And I'm very excited because you're not the only person who has shared that sentiment. And I don't know if it's the same in other diseases or other cancers, but that's something I really love about this community, is that the specialists, the doctors, the medical experts, it is this like symbiotic, two-way street between the patients and them, where we are working together. And it's not just like, I'm here and I'm telling you what to do. And you're not the first person to say that you learn from the show or from the patient's experiences too. And I just love that concept. And I think it's so important about working together to make the best plan and path forward, as I mentioned. So I just wanted to kind of echo that, because it's been shared before. And I think it's one of the reasons why this overall NET community is so strong and supportive of each other. It's just a beautiful sentiment. So I appreciate you saying that.
And, and other cancer communities are catching up to that, right? We see
even better.
And
influence in the world.
More and more being done in other cancers about including more patient advocacy, including patients in the voice, and physicians and patients working together, right? That's the whole idea. I think it started in NETs, and now we're seeing it everywhere.
I love to hear that. And it's like, when you say it out loud, it doesn't seem like it should be that strange, right? You're like, yeah, obviously, right? Obviously you should take into account the patient's experience, right? But I'm glad to see that culture shift happening, and I hope that we were a part of,
I think we are way ahead.
The catalyst. Yeah, I agree. And again, I'm no medical expert, but I see it very clearly in this community, and I will always take every opportunity to call attention to it, because I think it's such a beautiful thing. Okay, folks, go ahead and start sending in your question, but a couple more bits of housekeeping just to help you get your questions answered. So I mentioned we don't know your specific case, so you can't really ask very case-specific questions. It's hard sometimes because each case of this disease is unique, and sometimes I think people want to give me all the information to try to be clear or help, but it actually is too much, it's too nuanced, and it doesn't. So try to formulate your question in generic terms and ask them in little bites, little chunks. We've got 50 minutes. You can continue to ask as many questions. There is no limit, right? But if you try to wedge too much information in at once, it's hard for me to read it. I have to click on the see more thing. It just it's hard to get those questions answered. So if you think about it in little generic chunks, and then you answer one, which will probably lead to another question, as I'm sure it will, then ask that as well. Sometimes we may ask you to give a little bit more clarification. If you're still on the call, please chime back in, give me a little bit of context to attach it to your previous question, and we will do our best. But if we don't get to your question, we have the show every week. That's why we're able to keep it going. Inevitably, we don't, because we have so many questions. So if we don't, reach out to CCF. There's their website right behind me, carcinoid.org, or right here on the Facebook page. You can send us a message. We're going to do our best to get that question answered. And if you see a question in the comment section that you also have or you're interested in the answer to, just below the question, you can like it, love it, any of the emotions Facebook allows you to use. What that does is effectively upvotes that question. For me, if I see 8 people have the same question, I'm definitely going to ask that. So it just helps me get those high demand questions across to the guest today. So go ahead and start sending in those questions now, and we will start taking them ASAP. But I love to see, I've seen a lot of people that I haven't seen before today. That excites me. So I want to say welcome to the show. Numbers looking great so far. First question comes from Jesse. How do you tell the difference between lymphoma and neuroendocrine when lymph nodes are involved?
So, we always feel tissue is the issue, right? So if a neuroendocrine tumor goes into the lymph node, when you actually, if you take a sample of that, you will be able to see what is in there, right? You can see if there's neuroendocrine cells that are growing, or is it lymph node cells, which are the T cells or the lymphocytes. These are the cells that make the lymph nodes. Are they proliferating or growing and things like that? Sometimes the problem is that these lymph nodes are deep, right? They're all lymph nodes run. Most of them run around where the blood vessels are. They just like to stay close to the blood vessels, and it's hard to biopsy them or take a tissue out of them. So in that situation, the neuroendocrine tumors, 80-90% of them have these special receptors called the somatostatin receptors. You may have heard about, if you've attended these conferences before, that all these tumors have this special protein, and we have found a drug that goes like a lock and key mechanism, goes onto these tumors. And if you attach a radiolabeled dye to it, lights up these tumors. So the net spot scan, or the gallium dotatate scan that we all talk about, is very specific to neuroendocrine tumors and will typically light up if the patient has a neuroendocrine tumor in the lymph node. Typically will not light up if it's a lymphoma. So that's a radiographic testing, but no radiological study is 100%. Tissue is the gold standard. So if they can take a biopsy, they know if this is one or the other, but even scans can tell you that.
Tissue is the issue. I like it. And folks, as you can see, Dr. Vijayvergia is very clear in explaining things, even for someone like me who doesn't understand them so easily. So you're in for a treat today, because she explains concepts very, very simple. Is not simple in terms of understanding. So I like the way that you phrase that. Speaking of simple, I always, the net community is very well educated. So sometimes the questions on here are really like thought-provoking, potentially even controversial, but we still have new people, as I've alluded to, every week, new to the show, new to this disease. So I always love questions like this next one, which really lay some foundational knowledge for people who are new to the disease. Robin says, could you explain the hormonal aspect of NETs, as well as well-differentiated and poorly differentiated?
Absolutely. No, I think we have also spent a lot of time understanding from different degrees and different angles what makes some of the tumors, hormonally secreting and give symptoms, while others, same neuroendocrine tumors, not producing hormones and not giving you symptoms. I don't think a lot of us know why that happens, why 40% of neuroendocrine tumors have symptoms of the carcinoid syndrome that we call. Why some produce hormones and some don't. It's just, it's like, why am I, if I'm a very happy person or I'm a more serious person, it's just like different personalities. You think of it that as for neuroendocrine tumors. Some of them, neuroendocrine tumors have this special ability that they're filled with these special chemicals called, we call them hormones, but these are chemicals that can be released or overproduced when these tumors grow. And these special chemicals or hormones can go in your body, can circulate in your body and cause symptoms. The excessive diarrhea some patients have could be from the hormones that are released. Some people get flushing where the face turns red and feels hot, but they don't actually sweat with it. Some people develop, if it's a pancreatic neuroendocrine tumor, you can produce extra insulin that can make your sugars go down. Like, these are different kinds of special hormones that these tumors produce. And we do not know why some do and some don't, but it is in general, the different hormones probably lead to symptoms that we can see. So that's the hormonal aspect. And this is a very unique thing of neuroendocrine tumors. There's some other cancers do something like this that is called paraneoplastic syndrome, which is again, there's some weird hormones that they produce and cause symptoms, but that happens in less than 10% of the cancers. Here, up to 50% of its tumors present hormones. So that's why it's much more common in this disease. The second part about difference between well and poorly differentiated. So, for the longest time, so first time, this term carcinoid started back in 1907 from a German pathologist saw these cancer cells, these cells that looked like cancer and they were growing like cancer, but they still were very similar to normal neuroendocrine cells. We all have neuroendocrine cells in our body. They just look very normal, close to the normal appearing cells, but then they had the ability to grow uncontrollably and the ability to spread, which is the hallmark for cancer. And so they called it cancer-like, but it may or may not be, because I'm not sure, I'll call it cancer-like, so it became the term carcinoid. Now, over the years, when you find one, then you start digging, and the mind can only know what eyes can see, what the mind knows. So now they knew about this entity. Now they started looking into it more in detail. And then over the years, we found that these tumors are a spectrum of diseases. Okay. And that spectrum is defined by how these cells look under the microscope. Like, do they look like normal neuroendocrine cells, or do they look like just a sheet of cells just dividing and quickly that they don't have time to differentiate into looking like normal people or normal cancer cells? And so those are well differentiated or poorly differentiated cells. And then that also depends on if they're dividing fast, you look at what is the dividing rate of them. And we calculate that by a special stain called the Ki-67. That is just a special marker that when we get a tissue, we put on it, and we basically tells us how many cells are actively dividing at any given time. So think of it, if less cells are dividing, probably slow growing cancer. More cells are dividing at any given time, probably fast dividing cancer. If you have a fast dividing cancer, you don't have time to differentiate into what looks like normal. So those cells tend to become poorly differentiated. So this whole spectrum of neuroendocrine tumors from different grades, 1, 2, and 3, based on how fast these cells are dividing, how they look under the microscope, helps us define how aggressive we should be about treatment too, and how long the patient will survive with this cancer, or what it means in terms of their longevity, because these are all important questions that come to our mind. And these are some clues that help us define that. None of us are God to predict, but these are, from scientific data, we help our patients make the decision and help us make the decision of how we should treat them.
Got it. Thank you. A great question, Robin. Folks, two quick things. One, I forgot to mention this in the announcements at the beginning. At the bottom of your Facebook screen when you're viewing this, there's a few icons in the bottom right corner. And if you want to turn on closed captions, it's the CC button. If anybody that is hearing impaired, or you're trying to sneak this session in at work, or even if you're in the coffee shop and you forgot your headphones, if you want to see the subtitles, just hit that button and that'll help you along. And two, I'm scanning ahead of some of the questions. You guys are asking great questions today, but also doing a great job of what I asked in the beginning of just liking that question if you also have it. So we're covering a lot of ground. Great job so far. Next question comes from Richard. When is it appropriate to get a bone scan or even a whole body scan? And several other people have this question as well.
Okay. So, in this cancer, the gallium dotatate PET scan that we talked about, so this is a special kind of PET scan that is very specific for neuroendocrine tumors, because it basically goes and attaches to that protein, the lock and key that we talked about earlier. And that is a whole body scan, right? So that scans you from top to bottom. It scans the bones and everywhere else. So typically, because these cancers are sometimes they may not be dividing as fast. So the run-of-the-mill bone scans that we have, that we use for, it's a fluoride scan. So those scans that we use for breast cancer or other types of cancers may not light up when we're using it for neuroendocrine tumors, because all these cancers depend on the uptake of that chemical into these tumors, which lights up on the scans. And if the cancer is dividing slowly, the uptake may not be enough for us to see it. So your typical PET scans, so like the FDG PET scans that we do for other cancers, your typical bone scans, the sodium fluoride bone scans that we do for other cancers, are not the best to study these cancers. Instead, a PET scan, which is specific for neuroendocrine tumors, the gallium dotatate PET or the copper 64 dotatate PETs, both of these are equally good, are the two that we use for this type of cancer. And they are a whole body scan. They actually scan your bones. So they do everything we need. And they look at all the others. So we don't do separate scans for bone and one for the body. One can do all of these things. The only problem with these PET scans are that it doesn't give us a good idea of the sizes of the tumor. So I use them as like a initial land mapping thing where I know where the disease is. And then if I tend to do CAT scans or MRIs to follow the tumors, because the sizes are much better appreciated on that type of imaging rather than the PET scans.
Got it. Hey, thanks for your question, Richard. Next question from Kirsty. What is the chance? This is a common question. What is the chance for this disease to be passed down to children? Does it get passed down?
So I actually wrote a section about this in one of the guidelines for it. So I sort of know the data a little bit, by numbers. So 10% of neuroendocrine tumors are genetic, so passed down through generations. 10%, 90% are not. So the incidence is small, but 10% is still a big number, right? So there's these special genetic syndromes, von Hippel-Lindau. There is a disease called neurofibromatosis, tuberous sclerosis, and multiple endocrine neoplasias. So these are just some syndromes that are known to be associated with neuroendocrine tumors. Typically, pancreatic neuroendocrine tumors have a much stronger chance of being genetically related, more so than carcinoids of the small intestines and etc. So my practice, any of my patients who's under 50 or young and has a pancreatic neuroendocrine tumor, I recommend doing germline testing to make sure they have no genetic cause, refer them to genetic counselors to make sure that this is not a part of a syndrome that we have unearthed and that needs to be taken care of. But other than that, the chances of you passing it on or you got it from somewhere is extremely low. There are a few families, like some families where carcinoid just runs in the family, like everybody is affected. There's a few families in the NIH, like sort of we send those patients to NIH and they keep a track of them.
Yeah, that's what I was going to ask. There's a study going on right now at NIH, right? Can you elaborate on exactly what genetic component or that they're?
Yeah, they are just looking for genetic causes. So in that study, they don't know because, as I said, we don't know. The literature is limited on what other causes are there for genetic, like it being transmitted. But there are some families who have, like families, I don't mean like a small family, it's just pedigree, right? Great grandfather, from there it's coming down. So multiple people in different generations are affected by neuroendocrine tumor, but it is not one of the 3 or 4 things that I just told about or that we know of.
Right.
And we are trying to understand what's wrong with them. So at NIH, what they're doing is they actually have this study where pretty much most patients who have neuroendocrine tumors can just go and enroll. They get seen once a year. They do a ton of blood work. They do every mutational analysis that we can think of, that you can think of on all of these patients over time, just to see if over time they will get enough data bank, enough samples that they can identify something else. Like, for example, BRCA mutations were only thought to be related to breast cancer, ovarian cancer. Now it's a big thing in pancreas cancer too. Only by testing did we find out. So those kinds of things we're hoping to know as time moves on. But at this point, we don't have that much information. But yeah, if there's somebody who has the ability to go to NIH and get enrolled in that study, it's for the bigger good for the entire community.
So folks, this is actually apropos of the documentary series episode I was mentioning earlier in the show that's coming out in a week or two. Our patient, Mel, is part of this study. His mother had a neuroendocrine tumor. He does. And they believe his grandmother did, although at the time they didn't diagnose it as such. But this is an interesting overlap. So for Kirsty or anyone else, that episode comes out on, I believe, the 26th, whatever the Monday is, the last Monday of this month. Yes, the 26th. So that's just an interesting component. We don't dive we're talking about his story, so we don't dive too deeply into that, but it's just interesting that we're talking about it today because the patient that's featured this month is literally in that study. So hey, we'll stay tuned on that study and see what we find.
If anybody has the ability, it's just, it's hard to go down to, like, if you don't live
Right.
around that area.
Correct.
But if you are able to, I have few patients in my practice who I send to who are able to go down, and they just become a part of the study, because we will only know once we study.
Sure. Yeah. And we get this question all the time. You know, many people liked that question as well. So, and you mentioned PNETs. I have a question from Mary that says, for folks with advanced PNETs with stable disease, are CT scans sufficient with PET scans reserved for a change in status? Or should it be folks receive a PET scan on a regular schedule regardless of stability?
I don't do regular scheduled PET scans for people.
Okay.
I typically save them for if I cannot put two and two together with the imaging and the physical exam and labs for my patient. So, if I do you tell me, my patient comes and tells me I'm feeling terrible, I've lost some weight, I have some more pain or some symptom that makes me concerned, and the CAT scan showing that things are completely stable, these two things don't add up. If they don't add up, my PET scan helps me identify what the problem is and make sure it's not the cancer that's causing my patient to feel worse. If my patient's feeling well and the CAT scan looks good, I typically do not consider doing a PET scan for them.
Got it. Thank you. So another kind of fundamental question Donald and many other people have, and you've alluded to this, you've used this expression today. We often hear that nets are slow growing. Mm-hmm. Really, the question is, what does that mean? But Donald says, how is that defined? Is it 1 centimeter per year, 1 millimeter per month? What is it?
So that is actually defined not so much by the size of how much they grow over time. It's, I told you about how many cells divide at any given time. So your typical cancers, like, typical, I would say your, patient that there's a lot of awareness about breast cancer, pancreas cancer, or colon cancer. In those types of cancers, you look at that score, the Ki-67, which is like how fast the cells are dividing. That number is anywhere between 40 to higher percentage, more than 40%, right? So those are faster dividing cancer cells. Neuroendocrine tumors, so there's the well-differentiated neuroendocrine tumors, their Ki-67 score can range from 1 to 100, but most of these are ranging from 1 to 10%. So you can see the difference, right? 40%, that here the amount of cells that are dividing at any given time is less. That doesn't really mean it always translates into the patients, like that it will continue to grow at like 1 centimeter per year, sort of. They have spurts of growth too, right? I have patients whose cancer grow a little bit, and then I do a scan and, I say, all right, let's just do a scan in 2 months, nothing changes. And then it's not growing for the next 2 years. So this growth can even come in spurts sometimes, but it's more of like how, when we look under the microscope, what is the biology of this cancer, how fast it is dividing, that defines slow versus fast growing. But slow growing has its own set of challenges, right? The biggest challenge being everybody is trained in oncology to do scans every 3 months. And then we look at the scan from last time and we say, oh, nothing's changed. You do the next scan, nothing's changed. You do the next scan, nothing's changed. But then to know that, oh, these are slower growing cancers. So in 3 months, they will not change.
Right.
But if you look at, it's like, me living with my kid who I don't think grows at all, but I see him every day. But if someone sees him in 2 years, we'll be able to see that difference, right? Yeah. So it's always important to check the scans and look them over the year. So how did they do over the last year when things are changing or not is very important, because that is a very important challenge that we have to deal with.
Totally accurate about the kid growing, by the way. I'm going through that right now.
Yeah.
A similar question from Latoya. What is considered stable with nets? Can you give me some example?
Mm-hmm. So stable is a very, technically, so per the radiological guidelines, if a tumor has not increased by more than 20% from baseline, or decreased 35% from baseline, it is called stable disease. Okay, so whatever your baseline was, so when you started, so if I start somebody on a new treatment, right, today, their scan shows that their tumor length is X centimeter. If on the next scan or future scan or any scan from that baseline image, if the increase is greater than 20%, you call it progressive disease. If it's decreased less than 30% difference and it's decreasing, you call it a response. Anything in between, that 50% mark, 20% plus or 30% less is all considered stable disease. Right? That's a technical term, right? Nothing, that's how when we do clinical trials, we go by right then, because we have to be. But when I practice in clinic, for me, stable is a combination of two things: how my patient is tolerating the treatment and feeling clinically. Yes, I feel very similar to how I did before. I'm not losing weight. I'm feeling good. And on the scans, things are not growing, compared to what my baseline was. If it's not growing over a certain degree, 20% is a number, but I typically feel that if the changes are enough that I can see it with my own eyes, I would consider that to be a progression. Because, when you're seeing a patient, I'm not just following you're not just a number that I'm following. It's how you clinically feel and your scan together. If both of them look similar, you're definitely stable. If one of them is like not matching up, so you're clinically not as stable, you're feeling not as good, but your scan looks stable, I don't rest there. I don't think that's stable. I have to do more testing. But if you're clinically doing great and your scan showing progression, I actually don't even call that progression. I confirm that with the scan in a month or 2 months again before I jump the gun and move to the next line of treatment. So it's a combination. You don't want to, this is a marathon and not a sprint. You've heard it from a lot of people in this disease. We have X number of treatments. We got to use them judiciously so that we don't give you long-term side effects either. So these clinically, we base our decisions on our physical exam, how the patient's been doing, and also how the scan looks.
Got it. Thank you. Next question. Appreciate that, Latoya. Hopefully that helps. Next question from Glenn. I'm about to start Lutathera. What can I expect? So big question, but I think important because many people are in Glenn's shoes at times.
Yes. Hello, Glenn. Well, I hope you do great on the treatment, first of all, and I hope it works for you. But in general, Lutathera, I'm sure everybody's different, right? I've had patients who've been literally feel like, why can I not go to work from here? To others people saying that, how can somebody even think about working after this treatment? Everybody responds differently. But in general, the day is long, right? You come in the morning, you get blood work, then you go in to that special room, you start that protein solution, then you get your drug, and then we in our center also check blood work after that. So it is a long day that you're here. So that day you just go home and rest because you've been here all day. There's anxieties through the roof. You're starting a new treatment. But most people may feel a little queasy that first day. So we have some nausea meds, available for those if you need it. But most people after that have no major side effects. A little fatigue or tiredness is the one that I have heard the most for my patients. But within a week or 10 days, that gets better. And then you should be starting feeling better. Patients who have a lot of diarrhea from their carcinoid, they start feeling benefit within 3 or 4 weeks of getting their treatment. And I do know Glenn very well, so that's why I'm mentioning that point. But in general, so you would start feeling improvement within the next 3 to 4 weeks in your symptoms to some degree. The blood counts that go down with this treatment is not something patients feel at all, right? It's something that we just watch on your blood work. But from your standpoint, you shouldn't feel anything more than that. That's the norm. Extremes are always there, but typically that's how patients feel after the treatment.
All right. Thanks, Glenn, and good luck. Keep us posted. Next question from Steve. My wife has severe carcinoid syndrome and is collecting her emergency booster octreotide injections tomorrow. What results have people had that use these?
So I have had my patients have very good. That is the whole reason why there's a big market and so many pharma companies are working on getting an oral pill for that emergency medicine octreotide use. So, currently octreotide is only available as injectables. You can give it under the skin or intravenously, or you get the shot at once a month. And I have had patients who use the breakthrough shot during the last week for the longest time, and it does work. It does help their symptoms significantly. Sometimes the problem is the diarrhea is a mixture of a lot of things. It's not just the carcinoid, it's pancreatic insufficiency, it's the surgery. So you have short bowel syndrome, or basically because you had the surgery on your intestines that make, the anatomy gets different, that it may not be as beneficial, but if it's really related to carcinoid, those emergency shots help a lot. There's a lot of studies being done out there which are trying to replace that shot with a pill. And hopefully in the next few years we'll get results, and that's something we will be able to offer to our patients too.
All right. Thanks, Steve. Hopefully that helps. Good luck to you and Anita.
Really
Next question from Bess, which is a little case specific, but I want to ask it and we'll see if we can help her out because I think she's a little frustrated. Some cutaneous metastases lesions are enlarging aggressively. Please suggest info or direction for effective treatment. I've completed 6 PRRT infusions in March 2022 and monthly lanreotide since 2014. Did you pick up all of that?
Yeah, I do get it. I actually have a patient just unfortunately in the same situation. I'm sure that those lesions might hurt you too sometimes. And so I think you completed PRRT in March. I'm not sure with the lesions started after the PRRT or before. So that's something, is this like something that you failed the PRRT and now those are growing, or was it before and the PRRT helped some or it did not help some? But I'm assuming, just to answer this question, that you got PRRT, then these grew, or you had them before too, but they're growing even after PRRT at this point and causing problems to you. So one thing I do is when things are growing faster than I otherwise would expect for neuroendocrine tumors for a lower grade, I tend to biopsy. I don't shy away from rebiopsying these lesions to make sure I'm dealing with the same problem. Is it become a higher grade, or is it become a little more faster dividing? Right. Because for the faster dividing ones, chemotherapy has some benefit. If they're still slow growing and slow dividing slowly, then chemotherapy has no role in that treatment. So I like to biopsy. I typically do that. And then also, there are a lot of other treatments. If it's a low grade, there is a pill called everolimus that we use. There are other treatments that are out there. So I think you probably should discuss with your doctor. I just don't know exact story, but if someone who has progressed on PRRT, so if someone who has a cancer that's not responded to the PRRT as we would like it to, in that case, we have these other options available. I'm not entirely sure with your case as to how that will apply to you, so I apologize.
Hey, Bess, if hopefully that helps, but if you do have any other information, like when that started happening, just chime in a little bit later with that comment and just give me some piece of context so that I can remember your question earlier. But thank you so much. But this does lead us to our next question, I think, very well. Rebecca says, I'm seeing that this cancer grade is changing more and more, like low grade changes to mid or even high grade. The question is, what causes this and how, if possible, do we stay on top of it?
There's a lot of work being done to identify as to why the grades change. We have ourselves published a paper about a specific mutation that if neuroendocrine tumors have that specific mutation, they might be a slightly higher risk of changing. That's just, these are early studies. None of these are conclusive enough to say that, oh, this is something we could test and we should follow. In general, we are seeing this more often now because we are able to biopsy a little bit more. We do more imaging and scans that we can pick up these things, and we have treatment options that we can treat differently, right? Previously, we didn't have a lot of treatment options. So trying to look for something that's not going to result in treatment options is not worth the pain or the stress of going through a biopsy. But now we have better options to do all these treatments, new treatment options that these can be handled much effectively. We look for it. These are, as I said, there are a lot of research being done in this area to identify why that happens. We think it's because of some genetic thing, like not something that you passed on, but like the genetic makeup of the cancer itself, that there might be some special genetic makeup that makes you more prone to change grade into a higher one. I've never seen a higher go into a lower. I've only seen lowers go into the higher grades. They differentiate because what happens is the low grade tumors, your body immune system or something overcomes them. And, the more resistant ones select themselves and then start growing as time moves on. So it is something that, we are seeing. We obviously see it very commonly, more often in pancreatic neuroendocrines than others. But I think we need a little more research to exactly tell you why that happens.
Got it. Thank you. I appreciate that. And great question. How about a lung net question?
Sure.
So Fred says, can a person with a very slow growing lung net, 1.4 centimeters since 2014, can they live without surgical intervention or treatment and just surveillance? Also, would a pulmonary function test help with evaluating the overall condition of the lungs?
Pulmonary function tests, absolutely. That's the role of them. They help to identify the overall function of the lungs. Whether I don't think a 1.4 centimeter tumor should affect the function of the lung in any way. God has given us two big lungs as a reserve. If someone has underlying lung issues, some kind of lung disease that's underlying it, then it can, but otherwise it shouldn't. In terms of a low-grade lung net, surveillance and observation is a well-known strategy for those tumors. So, every patient is different. If I have patients with lung nets who we just surveil, we do not operate on, but it's a very case-based. So, what I would say is yes, surveillance is something that is practiced often for low-grade lung carcinoids. The question of whether it's appropriate for you or not is not something that I can comment on at this podium itself, but it is something that we do very often.
Got it. Thanks, Fred. Good to see you. Richard is following up with the question earlier about the whole body scans, the bone scans, and says, when, however, would you do one of those PET scans of the whole body?
Like the net spot, the gallium PET scan. So as I said, typically the times that I consider doing them is at diagnosis. So once the first time we diagnose a patient, because we need to know a lay of the land, right? We need to find out where the disease is. And it also helps me identify if PRRT or Lutathera, which is a treatment option for this cancer, would that, only if your tumor is positive on this PET scan, will that treatment be an option for you? So I think it helps me understand what treatment options are available for my patient, explain to them whether, octreotide or any of those shots are going to work, how well they're going to work. So I do it at baseline. And then after that, I do it if and when clinical and radiological pictures don't match. So if you have my patient's CAT scan stable, but they're having more pain in the back, well, maybe that's a time to consider something like that. Or if they're losing weight and like clinically they're not feeling as well, but this rate for the CAT scans or the MRIs are looking stable, then I consider them. When I'm considering PRRT for a patient, I consider doing a PET scan prior to that if my baseline scan was more than 2 years old from when I'm doing it. We also do PET scans before surgery, right, to make sure we know what we are going after and something's not left or we are ignoring. Many times we see bone lesions on PET scans that we don't see on regular scans because they're very tiny. We just see it on PET scans because PETs are so sensitive that we just need to know when we have a discussion with the patient to make those decisions. They're very, the use of, sometimes I use PET scan because for just diagnosis purposes too, when the tumor is in such a location that biopsy is impossible to do, near a net spot scan or a detect net or whatever, these dotatate PETs can help to evaluate those too.
Got it. Thank you. Thanks, Richard. Just want to send a quick little shout out to Dr. Aman Chauhan, who's in the audience and saying greetings from Kentucky. And just want to confirm that, yes, indeed, doctors do watch the show.
Absolutely.
Absolutely. I'd like to think it was because of my charming personality, but it's probably because, as Dr. Vijayvergia said, they are learning from you folks and the great questions that you ask. But we love Dr. Chauhan, so sending him love back. Comment from Jesse back to when we were talking about the genetic component. I have MEN1 and we've traced it back 5 generations. So wow, Jesse, that's a lot. You all have been doing your work. So
absolutely. And thank you for working, because it is a lot of commitment to do all that counseling workup, and like how much I cannot imagine how much work it is, but how important it is to help inform your family and your loved ones.
Totally.
It's very important for doing that. It's a great point. Thank you.
It's a great point. From Marcy, my husband has stage 4 metastatic nets in his intestines. Both lobes of his liver, was small one in his lungs and one outside of his stomach. He's never had a heart problem, but 14 days ago, he had emergency open heart surgery for an aorta dissection. Could this in any way be associated with the nets? By the way, he's doing great. Good to hear that. And is in inpatient cardiac rehab, should be home in another 2 weeks. So I'm glad to hear that, Marcy. Dr. Vijayvergia, could that be associated in any way to the nets?
I'm sorry to hear about that, but I'm glad he's better, because aortic dissections are life-threatening conditions. So I'm really, really happy to hear that he's feeling better and he's home. He's going to be home soon, and I'm sure you're waiting for him at home. But so aortic dissections have not been directly related to neuroendocrine tumors, to my knowledge. What I do know is sometimes one of the neuroendocrine tumors are pheochromocytomas or paragangliomas. These are a special type of neuroendocrine tumors that arise or are related to the tissue that's above it's in the adrenal gland. It's like the gland that just sits above the kidney. It's a tiny gland, but it secretes hormone that manages your blood pressure. So PHOs and paras can sometimes secrete hormones that can make your blood pressure rise, and the blood pressure is a very strong risk factor for aortic dissection in general. So that could be like one connection where I can put two and two together, but not in a typical net of the intestine. It is not something that's thought to be related to the cancer per se, but unfortunately, despite we're living with this cancer, neuroendocrine tumor patients are at risk for everything else that other people are at risk for. And I just feel it's just an unfortunate coincidence that these two things happen together, but I'm glad he's feeling better.
As am I. Next question from Susie and many other people. What percentage of healthy liver is necessary to be considered for surgery to remove tumors in the liver, specifically for those with heavy tumor load in the liver?
Great question. It's very surgeon dependent, actually. Some surgeons, they want to have a good remnant of liver left. They usually, would operate. Some surgeons who are much more confident and they are much more experienced, may be a little more aggressive with liver surgery, others not. It also depends on what is the health of the underlying liver, right? The normal liver, how healthy it is, that also decides what the percentage is. So there's no magic number to it. There is literally, and what we typically feel is if the surgeon tells me that they can remove 80 to 90% of the tumor and still have a good healthy liver functional remnant left, they would go ahead and operate on it. So it's a very surgeon specific question, which I don't think I should answer because it is different for every surgeon that I've actually talked to. 40, some say 40%, some say 20%, some say 60%. Because there is no like right answer, and it's not just one thing. It's a very case specific too. Like which location is it? Is the location such of the tumor all on one side of one tumor on one lobe of the liver? They can actually work to hypertrophy or basically cause growth of the other side of liver so they can resect more out. So it's just but all of these are very surgeon specific questions. So the bottom line, the more important thing that we should get from this question is the fact that if you have liver only disease, or if you have disease that's not widespread, make sure or request to be seen by a surgeon. Okay. Do not just believe that it's stage 4, that, oh, no surgery is done. Please request to be seen by a surgeon and get their opinion about it rather than having me or a medical oncologist make that decision for you.
Great advice. Thanks, Susie. From Sherry, what is the difference in PET radio tracers and how is the choice between the two decided?
So there are two, right? As she's very well informed, but there are two. One is copper 64 dotatate, which is the DetectNet, and there's gallium 68 dotatate, which is the net spot scan. I feel I've actually seen these scans for patients, and there's no head-to-head comparison between the two, but in general, image quality is very similar for both of these scans. Availability is the bigger thing. It's like, Advil and Aleve. You have both drugs. You can use whichever you like. But in general, the TechNet, the copper 64 has a longer half-life. So in places which are further remote, that drug is easily transported because, these are radioactive drugs. So they lose their efficacy 6 hours, 4 hours, 6 hours, 12 hours down the line from when they were initially made. So, DetectNet has a longer half-life, so it is easier to use in places that are further remote from where the plants are, where these drugs are being made. But other than that, I don't think there's much difference between the two. My practice is if someone got a gallium dotatate scan at baseline, I tend to follow it with that. And if someone got a copper 64, I don't tend to mix and match them because I never want to create, a Fuji apple with a Gala apple.
Got it. From Kim, I am considered NED, no evidence of disease after surgery for ampulectomy. From nets in the ampulla, margins came back clear, but scans and EGD done every 6 months, they said, due to lymphovascular involvement, showing from surgery from biopsies. Can you explain what this means?
Yeah, so lymphovascular invasion, as the term suggests, is when they, like wherever they took out the cancer cells, the polyp or the ampulla, around that they took out some normal tissue, and there were tiny blood vessels in their capillaries, is how we call them. And there was tiny lymph vessels in that. That's normal, like all of our body has it. What lymphovascular invasion means that they were able to see one or two cancer cells invading into the lymph channel or the tiny capillaries or the blood vessel, the tiny ones in that sample. So when you have that, you worry that if the tumor was able to get to the blood vessel, could it, go into the surrounding tissue, like those cells can grow in the surrounding tissue or go into the lymph node or things like that. So that's probably the reason why they're watching you more closely, that if because that makes it a slightly higher risk than if they didn't see it. Having said that, we really don't know what it means to, like, yes, there's high risk, but nobody can quantify that, that really means something can come up or not. But we just watch to make sure that if that happens, God forbid, they can catch it early on and then can make you NED again. But I hope you just continue to be NED forever.
Me too. Thanks for your question, Kim. From Cecile, can having severe Crohn's disease could been an attribute to the neuroendocrine tumor in my husband's small intestine?
I have one patient in my practice right now who has Crohn's disease and neuroendocrine tumor at the same time. But having said that, it is not a common occurrence that these two cancers are related. When you have Crohn's disease, your body's immune system is, a little, I would say, abnormally activated. That's why you get the Crohn's disease in the first place. It's basically your own body's immune system's attacking the GI cells or the cells of your intestines. But how, patients who have Crohn's disease have a slightly higher risk of developing colon cancer, the run-of-the-mill colon cancer. So it could increase the risk of any cancer for that matter. But typically it's more associated with just colon cancer or risk of biliary cancers or bile duct cancers in general, not so much neuroendocrine tumors.
Got it. Thank you. Bess chimed in back in. This is about the aggressive cutaneous Mets.
Yeah.
She says these Mets were diagnosed in 2017, stable following PRRT until just 2 months ago when small abdominal lesions multiplied and one lesion enlarged to 2 to 3 centimeters, protruded and turned purple, very, very sensitive.
Oh, I'm sorry to hear that.
Yeah.
That must be hard. Especially, it's very difficult to be able to see the cancer too.
Yeah, for sure. Donna is referring to a previous episode that we had where an expert mentioned a test called ProGRP. She did not understand what this test is for, maybe for measuring the serotonin. Can you explain the purpose and method of this test? Are you familiar?
I actually am not exactly familiar with the test. I have to say I have not. So, there's a lot of work being done in terms of what could be a good biomarker for neuroendocrine tumors. Like chromogranin was used. We thought that was a great marker, but over time we've realized not really. It sometimes just goes up and down for no apparent reason. Now, sometimes it's helpful. 90% of the time it's not helpful. So more and more people like me and a lot of other practitioners have stopped even following that. It's just an extra bill that comes to the patient more than anything. Right. So we're looking for other biomarkers. Dr. Chauhan, that you talk about later, has actually done some work on a new biomarker too. Similarly, ProGRP, which is a gastrin-related peptide, it's also a marker that is one of the other things that could be, used in this cancer. I don't think it's validated enough to be used in practice. Yes, there's a lot of markers that go up and down, but is it good enough that its level or changes in level can help me make treatment decisions? Not really. No, treatment decisions at this point in time are entirely based on how the tumor shows over scans and how my patient is physically feeling. These markers by themselves do not help me change my treatment for the patient personally. So I use them more in a research setting, just saying that I need to learn more about them rather than use it, outside of a research setting in just routine patients, because we come back with the results and then I don't know what to do with it. That's not very comforting either. So I personally do not do that quite yet. I actually don't do a lot of markers in general because I just don't know exactly how to use them. There are some newer markers that are coming out. There is a test called the NET test or a PPQ. These are very fancy new tests that are being studied to show the benefit of treatment, to show how the disease is responding to the treatment. But again, these are also investigational at this point in time because we do not know how to change treatment based on these results. Hence, if someone has these tests go abnormal, we say, oh, let's do the CAT scan. We're anyways doing CAT scan every 3 months or 6 months. So I don't, it doesn't add extra information for me personally.
Gotcha. I know that you're heavily involved in research too. We talked about a few studies today specifically. Are there any that we haven't touched on? Is there anything that's coming up or being studied at the moment that you're excited about?
Yeah, I think, that's what keeps us going in this cancer, right? That there are there are studies that are ongoing. There are new drugs that are coming in in the market. There is a viral vaccine. There's a vaccine therapy study that's coming, hopefully we'll have soon in the future. There are people studying immunotherapy in different ways and how we can harness that. There are studies of newer pills, like pill treatments for this cancer. There's some new drugs, and we have some studies open at our center too in that area. How to improve on the PRRT, right? We have patients, we got PRRT. Now is the time a lot of patients are progressing on PRRT based on how to make that better. There's my colleagues, they have studies. Dr. Chauhan is proposing a study in that. So there's a lot of work being done in that area too. So different, I work on a lot of studies in high-grade neuroendocrine cancers too. And we are looking for some novel compounds and novel ways to how these patients become resistant to treatment, how we can reverse it. So yes, we are doing a lot of work, and we are hopeful that we will be able to change the course of this disease even more as time moves on.
It's funny when Dr. Chauhan commented, I saw somebody responded to him. You can reply to the comments, and they were like, "I want to be able to take the pill. When's it going to be available?" So people are staying on top of it for sure.
Exactly. Yes.
Kind of a part two to that question. What is the one area that isn't being studied right now that you wish was?
I think one area that is not really very well studied that should be is the resistant carcinoid. Yes, we are developing alternatives to octreotide, and telotrestat is one drug we use for carcinoid syndrome diarrhea. But I still feel the management of carcinoid syndrome, which is a huge symptom burden for patients, we really don't have that magic drug outside of octreotide, and which may or may not work. It does tie into better treatments for cancer, because if the cancer is controlled, the symptoms will be better, right? So, you do one, you work the other, but it would be nice to have some better, things up our sleeve to help our patients with the syndrome, with carcinoid heart disease, which is also a part of the hormone release. So that's one area that we are still lagging behind a little, and we need to do better.
I really like that answer. I know that patients are and the patient experience is very important to you. If I were newly diagnosed last week, scared, confused, haven't heard of this disease before, what would be your first bit of advice to me as a newly diagnosed patient?
My advice to you would be that we got this. We have things we can do. Yes, we got to do all the testing, and we need to find out so that we can treat you to the best of our abilities. But we have come a long way in this disease about understanding it. And though it's overwhelming, just go onto the CCI website, try to read some if you want to. Don't read from any untrusted sources. Get your information from trusted sources, but we will do things to make sure you feel better, and you're here for a long time. So that's what I would tell them.
We got this. I like that. I mentioned earlier, I've been working with CCF for a decade, and I feel really privileged because in that decade, so much has happened. I know we have a lot of activity right now, but in the past 10 years specifically, there's been what I would consider leaps and bounds, and I've been evolved at least tangentially to see that. So that's been exciting for me. Folks, that is our show for today. Richard says today's discussion has been a home run. Thank you. And Donna follows that up saying, thanks so much for the comments about disease markers. Very, very helpful. Your answers and comments are so articulate and easy to understand, Dr. Vijayvergia. That echoes the sentiment I was sharing earlier. And that's so important when we're talking about these things that can be really high level or full of jargon, right? For people to understand it. So I appreciate it very much. And so does the audience. And I appreciate your time. Thank you for being back here 1 year later.
There you go. Thank you. Thank you so much for having us. And I appreciate everybody for being here too and listening. So it helps us keep going, though, as said, as a physician, the one thing that makes me keep going is the fact that I make one life breathe easier because I spend this day doing what I'm doing. So thank you.
I love to hear that. And thanks to you folks at home. Again, as always, we hope this program helped answer some of your questions. And I'll reiterate one more time, you can reach out to ccf@carcinoid.org or here on the Facebook page if you have any follow-up questions, or tune in next week. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. Without their support, we couldn't do the show. And finally, my name is Rain Bennett. I have been your host. Thank you for watching. And please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.